Good morning. I'm Prof. Cynthia Yu from the discipline of Pediatric Dentistry, the University of Hong Kong. Welcome to my lecture titled Oral Health Care in Medically Compromised Individuals for Immunodeficiency and Infectious Diseases. This lecture will cover the oral manifestations and dental management of children with primary and also acquired immunodeficiency diseases. Before we talk about immunodeficiencies, we need to understand the basic concepts of how the immune system works. A general outline of the immune system is shown in this figure. The immune system consists of innate and also adaptive immunity. Innate immunity includes phagocytic cells like neutrophils, dendritic cells, and also macrophages. The neutrophils are short-lived and kill the bacteria via phagocytosis, degranulation, cytokine secretion, and formation of extracellular traps that immobilize and kill bacteria. In contrast, macrophages are long-lived and are the major immune cells involved in the later stage of the immune cascade. Also, part of the innate immune system are the natural killer cells for killing virally infected cells, and also complements which helps to clear pathogens via lysis, inflammation, opsonization, and phagocytosis. Both dendritic cells and also the macrophages are antigen-presenting cells. So these cells take up foreign antigens, internalize them, and present them to T cells. The adaptive immune system takes over when the innate immune response fails to overcome the pathogen invasion. The adaptive immune response is further classified into cell-mediated response provided by the T cells and humoral immune response by activated B cells and antibodies. There are 4 types of T cells. The first type is the CD4 helper T cells, which activate the B cells and other immune cells by producing cytokines. The second type is the CD8 cytotoxic T cells, which directly kill infected cells. The third type is the TRES, which regulate and suppress cells in the immune system. The last type is the memory T cells. They have extended lifetime and provide a rapid response to past infection. Bridging the innate and also the adaptive immunity is the antigen-presenting cells, which inform the adaptive immune response about an infection. Helper T cells respond to antigen-presenting cells, which activate B cells to secrete antibodies, macrophages to destroy invading pathogens, and cytotoxic T cells to kill infected cells. So now we can come back to immunodeficiency. So immunodeficiency is defined as the body's immune system not able to perform its normal function in protecting the host. There are 2 types of immunodeficiencies, primary and secondary. Primary or congenital immunodeficiencies occur secondary to genetic defects and usually lead to an increased susceptibility to infection at birth or in early childhood. Secondary or acquired immunodeficiency are much more common, developed later in life, usually as a consequence of infections, malnutrition, malignancy, or immunosuppressive medication. So for primary immunodeficiencies, it can be broadly classified into 4 categories. Firstly, the T cell defects. An example is the Durward syndrome. Secondly, B cells defects. Examples are agammaglobulinemia and selective IgA deficiency. Thirdly, combined immunodeficiency diseases. Examples are Wiskott-Aldrich syndrome and ataxia-telangiectasia. Last but not least, the phagocytic cell defects are involving the neutrophils. So we will start with the T cell defect, Durward syndrome. The cause is a deletion in chromosome 22q11.2. Patient presents with numerous abnormalities resulting from impaired embryogenesis of organs originating from the 3rd and also the 4th branchial arches. showing abnormal faces, cleft palate, cardiac malformations, hypoplasia of the thymus, and leading to deficient T cell maturation, as well as hypoplasia of the peripheral glands, resulting in episodes of hypocalcemia. Dental examination may reveal delayed formation and eruption of the permanent teeth, abnormal tooth shape, enamel hypoplasia, along with enamel hypocalcification. T cells are necessary for adequate B cell responses, so patients lacking functional T cells from birth often has a decreased antibody production, hence more susceptible to opportunistic infection like oral candidiasis and herpes simplex virus infection. Treatment, usually the T cell function of the patient improves with age. Next, we will talk about B cell defect. B cell defect is more common, contributing to 50% of all primary immunodeficiencies, generally having fewer oral complications than other immunodeficiencies. An example of the B cell defect is a gamma globulinemia. The cause is X-linked or autosomal recessive. Patient presents with normal T cells, but then absent or very low levels of B cells with reduced serum immunoglobulins. Patients with B cell defects often have bacterial respiratory and sinus infection, as well as enteroviral infections. Patients will present intraorally with recurrent bacterial infections, recurrent epis ulceration, odontogenic infections, predisposing them to septicemia. The conditions are managed by intravenous gamma globulins. The next condition with B cell defect is selective IgA deficiency. The cause is a defect in B cell differentiation with reduced production of IgA. Selective IgA deficiency is the most common disorder of the immune system. Patients usually present with an increased susceptibility to sinopulmonary infections, intraorally with candidiasis, and also oral ulceration. Prophylactic antibiotics may be prescribed. Subclass deficiency may require immunoglobulin replacement. After T cell and B cell defects, we also have combined immunodeficiencies. The first example is what's called Eldridge syndrome. The cause is X-linked recessive immunodeficiency affecting mainly males. The serum antibody patterns show low IgM levels and also elevated levels of IgA and also IgE. The T cells are decreased. General presentation, patient have a triad of symptoms including eczema, thrombocytopenia, and recurrent infections. Oral presentations mainly in the form of gingival ulceration and also palatal petechiae. Bone marrow transplantation is the mainstay of treatment for patients with what's called Eldridge syndrome. The second type of combined immunodeficiencies is ataxia telangiectasia. It is an autosomal recessive disorder in about 70% of cases with selective IgA deficiency, which may be associated with IgG2 deficiency and a low number of T lymphocytes in blood. Patients usually present with a progressive cerebellar dysfunction, resulting in ataxia, slurred speech, and also nystagmus. Oculocutaneous telangiectasia, diabetes mellitus, increased malignancies, progressive pulmonary disease secondary to infection. Oral presentation mainly in the form of recurrent hepatic gingival stomatitis and also candidiasis. Treatment usually antibiotics or gamma globulins infusion. So we have now covered the primary immunodeficiencies related to T cells, B cells, and their combinations. So we will move on to another type of primary immunodeficiencies related to phagocytic cell disorders, mainly involving the neutrophils, which can be divided into qualitative and also quantitative disorder. So we will start with the qualitative disorders, which can be subdivided into disorders and also phagocytic disorders. So for the chemotatic disorders, they are the examples are the Chediak-Higashi syndrome, lazy leukocyte syndrome, leukocyte adhesion defects. For the phagocytic disorders, the examples are the agammaglobulinemia, chronic granulomatous disease. So the first examples of chemotatic disorders is the Chediak-Higashi syndrome. This is due to a defective gene associated with defective transport of bacteria to lysosome and inability to kill phagocytosed bacteria. The general presentation is a partial oculocutaneous albinism, neurologic abnormalities, photophobia, nystagmus, recurrent pyogenic infections, malignant lymphoma, neutropenia, anemia, and also thrombocytopenia. The oral presentation usually severe gingival inflammation with a rapidly progressing early childhood periodontitis with early exfoliation of teeth. Treatment mainly aggressive antibacterial therapies, splenectomy, bone marrow transplantation. The second type of chemotatic disorder is leukocyte adhesion deficiency. It is an autosomal recessive condition involving deficiency in migration and chemotaxis of a leukocyte, as well as defect in their adhesion and transmigration through endothelial cells. The condition is characterized by delayed separation of the umbilical cord, recurrent bacterial infections, and also impaired wound healing. Oral presentation, patient may show marked linear gingivitis, rapidly progressing periodontitis with premature loss of teeth, slow healing ulcers with scarring. Treatment for the severe case, mainly treated with bone marrow transplantation or stem cell transplantation, the mild and also the moderate case with antibiotic therapy. So, an example of a phagocytic disorder is the chronic granulomatous disease. So, the cause 70% X-linked and then 30% autosomal recessive. So, the patients with this condition have phagocytes that engulf particles normally, but then fail to generate superoxide anion, hydrogen peroxide, and also hydroxyl radicals to kill the bacteria and fungi. So, for oral presentation, the patient will present with a recurrent fungal bacterial infections, oral candidiasis, gingivitis, and also oral ulcers. So treatment is usually in the form of subcutaneous injection of interferon gamma, and also antibiotic and antifungal prophylaxis may be necessary. So now we'll talk about the quantitative defect of a neutrophil disorder. This condition is defined as less than 1,800 neutrophils per microliter of blood. Life-threatening sepsis occur when the neutrophil count falls below 500 per microliter of blood. Neutropenia can occur in the following situations: infiltration of bone marrow by neoplastic cells after administration of cytotoxic drugs for childhood cancer, cyclic neutropenia, nutritional deficiency, viral and drug-induced neutropenia. And example of a quantitative defect of neutrophils is a cyclic neutropenia. So the cause is due to a mutation in neutrophil elastase gene causing defect in stem cell regulation, and there is a childhood form which is inherited, autosomal dominant. The neutrophil counts fluctuate from normal to less than 500 per microliter of blood on approximately 21-day cycles, with neutropenia lasting for 1 week. The general presentation varies from asymptomatic to severe infection of skin and mucous membrane. Symptoms often decrease with age. The patient may present intraorally with localized and generalized early onset periodontitis, gingival edematous, and inflamed with gingival recession, ulceration, and desquamation. Treatment is usually subcutaneous injection of granulocyte colony stimulating factor to increase neutrophil count. Periodontitis can be treated with plaque control and also antibacterial mouth rinse. So all primary immunodeficiencies predispose the child to opportunistic infections. In general, B-cell deficiencies have fewer oral complications. Periodontal diseases among younger patients are often associated with defects in neutrophil functions. The most noticeable oral manifestations of primary immunodeficiencies are the infections of the oral soft tissue. So we will start with candidiasis. So usually associated with Candida albicans, and this is the most common oral lesions affecting patients with immunodeficiency diseases. So oral candidiasis can be divided into 5 main types: pseudomembranous, atrophic, chronic hypoplastic, angular cheilitis, and also chronic mucocutaneous. So we'll start with a pseudomembranous candidiasis, which is characterized by presence of creamy white or yellowish plaques on the oral mucosa. Sometimes it can appear fiery red. So this type of candidiasis is usually found on the buccal labial mucosa, tongue, hard and soft palates. The atrophic candidiasis appears clinically as a red lesion, and when located on tongue, it is usually associated with loss of papillae. So the common locations are the palate and also dorsum of the tongue. For chronic hypoplastic candidiasis showed both red and also white areas and usually present bilaterally. For angular cheilitis, it is usually present as a red or fissure areas at the angle of the mouth, and usually caused by Candida albicans and also Staph aureus. For chronic mucocutaneous candidiasis, it is a persistent superficial Candida infection that may develop during the very first few months of life, producing granulomatous involvement of the mucous membranes, nail beds, scalp, and also the skin. So the next common oral lesions are the herpes simplex virus infection. So we'll start with the primary herpetic gingival stomatitis. It causes both oral lesions and also systemic manifestations. So the child may present with fever, malaise, cervical lymphadenopathy, perioral, and also oral lesions. So the lesions usually start as vesicles that rupture to become painful irregular ulcers on the gingivae and oral mucosa, as well as along the vermilion borders of the lips. For recurrent herpes simplex virus infection, it results from the reactivation of the virus latent in the nerve tissues of the patients with prior immunity. And usually, it causes clusters of small irregular vesicles without systemic manifestations. So these vesicles normally are found on the hard palate and occasionally on the gingivae. For recurrent herpes labialis, it may be seen alone or associated with intraoral lesions and is characterized by vesicles on the vermilion border of the lip which rupture and crust over. So these are the photos showing the occurrence of primary herpetic gingival stomatitis in a child patient. As you can see, there is inflammation of the gingivae producing a red and also swollen appearance. So there is a widespread ulcerative lesions in the buccal mucosa, tongue, gingivae, lips, and also the perioral skin. The other common oral manifestations include periodontal disease. In general, periodontal diseases among younger patients have been associated with defects in neutrophil function. So in the gingival tissue, neutrophils form the first line of defense against subgingival biofilm. So if there is any reduction or dysfunction of the neutrophils at the gingival crevice, this will lead to a marked increase in host susceptibility to periodontal diseases. Recurrent ephes ulceration. So recurrent ephes ulceration usually is limited to the non-keratinized mucous membrane, like the soft palate, inner lips, inner cheeks, and it will usually resolve within 10 to 14 days. Patient may also present with a premature exfoliation of the primary teeth. This is mainly due to the defects in neutrophils. So these are photos of a patient with a cyclic neutropenia. So the photos on the right hand side are taken at 3 years old, and then on the left hand side are taken at 4 years old. So in general, you can see that the patient presents with poor hygiene, severe gingival inflammation, and also gingival recession. So we have covered the primary immunodeficiencies. So now we will talk about secondary or acquired immunodeficiencies. So this can be due to human immunodeficiency virus infection, or it can be drug-induced immunodeficiency, for example, by cytotoxics, corticosteroids, and cyclosporin A. It can also occur in children who have undergone bone marrow transplantation and also radiotherapy. So today we will focus on human immunodeficiency virus infection. The World Health Organization estimated that the number of people living with HIV in 2020 to be around 38 million, and people newly infected with HIV in 2020 will be around 1.5 million. Of the estimated 38 million people living with HIV worldwide in 2020, 1.7 million were children below 15 years of age. Each day in 2020, approximately 400 children became infected with HIV, and approximately 270 children died with AIDS-related causes, mostly because of inadequate access to HIV prevention, care, and also treatment. There are two types of HIV that cause disease, HIV-1 and also HIV-2. So most HIV-2 cases are found in Western Africa and result in a less severe clinical disease spectrum. HIV-1, on the other hand, it has a worldwide distribution and is responsible for the HIV/AIDS pandemic. There are two major routes of transmission of HIV infection in children. So over 80% of the cases are vertically acquired from an infected mother, which occur before, during, and after birth. And then secondly, from blood products, with children with hemophilia being most affected. Vertical mother-to-child transmission has significantly decreased with the use of antiretroviral therapy in pregnant women and their babies. The major target cell for HIV infection is the CD4 lymphocyte, which are the helper cells. The CD4 lymphocyte depletion is associated with increased risk for opportunistic infection. So this is a table showing the clinical stage of HIV infection, which is classified into stage 1, 2, and 3 based on the CD4 cell count and also percentage according to the different age group. So this is another table showing the clinical stages of HIV infection. So for stage 1, there is no suppression and no history of AIDS consistent opportunistic infections. For stage 2, there is moderate suppression, and then no history of AIDS consistent opportunistic infection. For stage 3, there is severe suppression based on CD4 values or history of AIDS consistent opportunistic infection. The clinical presentation, usually the child patient will present with a generalized lymphadenopathy, fever, persistent diarrhea, hepatosplenomegaly, failure to thrive, weight loss. They can also present with thrombocytopenia, neutropenia, and also anemia. Recurrent infections are very common, and they are more susceptible to bacterial infections than adults. Similar to children with immunodeficiencies, over 70% of HIV patients have oral lesions. Oral lesions are among the earliest and most common clinical signs of HIV infection among children and adults. Patients usually present with oral infections such as fungal infections, candidiasis being most common, especially acute pseudomembranous candidiasis, followed by angular cheilitis. Esophageal candidiasis is the hallmark features of the condition, and it occurs when the CD4 counts drop below 100 milliliters. Viral infections is also common, especially herpes simplex viral infection. There are two main types of HIV-associated periodontal diseases. The first one is linear gingival erythema. So it presents as a red erythematous gingival tissue and can extend to free gingival margin. So it can result in spontaneous gingival hemorrhage and also petechiae within the gingival margin, either in a localized or a generalized form. Secondly, the other type of periodontal disease is the necrotizing gingivitis or periodontitis. The two most significant findings in these conditions are the presence of interproximal necrosis and ulceration with rapid onset of gingival pain. So the treatment involves mechanical debridement, oral hygiene instruction, and also regular reviews. Additionally, long-term use of highly active antiretroviral therapy may be associated with dysregulation of calcium homeostasis, bone loss, or diabetes mellitus, which may predispose the patients also to periodontal diseases as well. Salivary gland enlargement with parotitis is most common. Occurs most frequently in pediatric than adult patients. It can be unilateral or bilateral and results in xerostomia and pain. Reduced salivary flow may also lead to pseudomembranous candidiasis and dental caries. Patient also at high risk of oral bleeding because of thrombocytopenia. Recurrent aphthous stomatitis is very common in children. Also, dental caries in gingivitis are also common. The increased caries risk may be due to the reduction in salivary antibodies, the absolute lymphocyte count, and also the salivary flow rate. Patient also have an increased risk of enamel hyperplasia. Non-Hodgkin's lymphoma, Kaposi, sarcoma, and hairy leukoplakia are uncommon in children. The dental needs of children with immunodeficiencies or infected with HIV are best coordinated with the medical team. So it's important to consult the child's physician to establish current level of immunosuppression, and then consider the type of treatment to be included in the treatment plan. So for initial evaluation, it is important to maintain an up-to-date medical history information regarding recent hospitalization and also episodes of infection. We also need to check and know the type of medications that the child is taking, the level of immunosuppression. For hematological status, it is important to include a complete blood count, the CBC, with white cell differentials and platelet count, which need to be evaluated before initiating invasive dental procedures. So for the absolute neutrophil count, it is important to rule out the significant risk for infection due to immunosuppression. So we will look specifically at the absolute neutrophil count before treatment. So a absolute neutrophil count of less than 1,000 millimeter cubed indicates a significant increased risk for infection. For the coagulation status, the patient is at risk of bleeding because of thrombocytopenia. So it is important to rule out the risk for bleeding by obtaining INR, the International Normalized Ratio, and also the platelet count, and ask physician about any other possible risk for bleeding before any dental procedure. A physician consult is recommended for patients with a platelet count less than 75,000 or any other factors that which may contribute to prolonged bleeding time. We also need to assess whether the patient requires antibiotic prophylaxis. So a patient with a compromised immune system may not be able to tolerate a transient bacteremia following invasive dental procedures. So the decision regarding the need for antibiotic prophylaxis for dental procedures should be made in consultation with the child's physician. We also need to go through the patient's dental history, including all past dental treatment provided and any complications associated with dental treatment. After that, then we will have to do a clinical and also radiographic examinations, complete head and neck, extraoral examination, including cutaneous tissue, regional lymph nodes, major salivary glands should be performed. And then the extraoral examination should be followed by a comprehensive intraoral soft tissue examination as well as hard tissue examination together with an oral hygiene assessment. A comprehensive treatment plan should be formulated on the collected information and phased in terms of priority of care, addressing the patient's pain, eliminating any oral infections, restoration of deceased teeth, and also treat the periodontal diseases, and also provide oral hygiene instruction and education. So for management of oral infections, it is important that appropriate diagnosis and also aggressive treatment of the oral infections is essential in a patient with a primary immunodeficiency disorder. Both the risk of infections in general and the risk of infection caused by the opportunistic organism increase in the immunodeficient patient. Candida infection must be treated promptly and also vigorously in any patient with immunodeficiencies. So for oral candidiasis, nystectin droges or oral suspensions are effective. If the candidiasis fails to respond to nystectin therapy, clotrimazole oral droges or systemic fluconazole may be indicated. Herpes simplex virus infection, the lesions are extremely painful and many children refuse to eat and drink. So early diagnosis and treatment with antiviral agents such as acyclovir are critical in the management of these infections in immunodeficient patients. Necrotizing gingivitis and also periodontitis. So treatment include improvement of the patient's oral hygiene, plaque removal, chlorhexidine rinses, and also metronidazole if necessary. Management of oral conditions for patients with reduced salivary flow, artificial saliva substitutes or oral lubricants can be considered. For patients with salivary gland enlargement, usually no treatment is needed. For patients with oral bleeding, management is usually by local approach, for example, application of a pressure pack. Treatment of recurrent adverse ulceration is usually asymptomatic. Ensure patient has adequate hydration and prescribe analgesia if necessary. For patients with linear gingival erythema, again, we have to reinforce oral hygiene and then carry out enforce optimal plaque control, chlorhexidine rinses if necessary. When treating a child with HIV or immunodeficiencies, the dentist should adopt a active preventive approach and have a policy of frequent and also thorough oral examination so that the related oral infections and complications can be identified and treated at their earliest possible stages. Prevention is very important for children who, because of immunosuppression or the side effects of the medical treatment, may be more susceptible to oral diseases. So for oral hygiene, it is important to reinforce toothbrushing twice a day with a regular soft nylon brush or even electric toothbrush. And if possible, then encourage the child to carry out flossing daily. Patients with poor oral hygiene or periodontal disease may use chlorhexidine rinses daily until the soft tissue's health improves. Dental practitioners should also discuss the importance of a healthy diet to maintain the nutritional status of these children, with an emphasis on food that do not promote caries. Other preventive measures include the use of fluoridated toothpaste, topical fluoride varnish, fluoride rinses, and also fluoride gel for patients who are at risk for caries and also with xerostomia. So for provision of the dental care, so we have to consider the prevention of infection. So we look specifically at the absolute neutrophil count. So for elective dental care, if the count is more than 2,000, there is no need for antibiotic prophylaxis. However, if the count is between 1,000 and 2,000, then antibiotic coverage should be considered. If it is less than 1,000, it is important to defer dental treatment. So for emergency treatment, it is important to discuss antibiotic coverage with the medical team before proceeding with the treatment, as the patient may require hospitalization for dental management. Another factors that we need to take into consideration is the platelet count, because these patients usually present with thrombocytopenia and is at risk of bleeding. So for elective dental procedures, if the count is higher than 75,000, no additional support is needed. So, but if the count is between 40,000 to 75,000, then platelet transfusions may have to be considered pre-operatively and also 24 hours post-operatively. Localized procedures to manage prolonged bleeding may include the placement of sutures, the application of hemostatic agents, and also pressure packs. For counts below 40,000, it is actually better to defer dental care. For emergency treatment, it is important to contact the patient's physician to discuss supportive measures, for example, the need for platelet transfusion and other bleeding control measures, and also the need for hospital admission and care before proceeding to any dental treatment. In addition, we also need to consider localized procedures such as microfibrillar collagen and also topical thrombin or any additional medications as recommended by the hematologist that may help to control oral bleeding. During provision of dental treatment, we will adopt a minimally intervention strategy. So now we can apply silver diamine fluoride for arrest of dental caries, and we can also use a traumatic restorative technique for placement of fissure sealants and also restorations. And we also can use the hot technique for placement of stainless steel crowns. For those pulpally involved primary teeth, it is better to do extraction than endodontic treatment to avoid septicemia. So in patients who are at risk for increased bleeding, then deep block injections should be avoided. In these patients, intraligamentary or local infiltration may be a more appropriate alternative. And we also have to consider the local measures to control bleeding, as we have talked about just now. So 3 to 6 monthly recall schedules should be instituted to monitor any oral changes or oral infections. So, in summary, in this lecture, I have outlined the frequently occurring primary and secondary immunodeficiency disorder in children, along with their etiology, general, and also oral presentations. So, immunodeficiency have a profound effect on the oral tissues of children, and oral infections are a common feature of these diseases. So, prevention of dental caries and periodontal disease is imperative because of the high risk of infection and also potential risk involving in the dental treatment. Therefore, regular review of the dentition, gingival mucosa, and the institution of a preventive program are essential for maintenance of the healthy heart and also soft tissue for this group of children. So thank you very much for your attention.